Welcome to Day's Clinical Skill, where we will explore patterns of pain. This skill is not only important for trained professionals, but it is also important for patients to understand the critical role of exploring, then accurately explaining their patterns of pain for an appropriate assessment of their presenting complaint. This video is for educational purposes only and is in no way a substitute for advice from a qualified medical professional. My name is Tira Ashby. I'm a chiropractor and osteopathic practitioner. I'm happy to share with you these important clinical skills that I've learned in my 25 years of practice. An often overlooked area of history taking is teasing out the nuances of the patient's experience with pain. It is estimated that over 90% of the practitioner's understanding of the presenting complaint comes from the history alone, specifically from the exploration of pain patterns. Patterns of pain and discomfort are the patient's experience of what is going on and is their gauge on how things are changing. The more you can tease out the specifics about a patient's experience with pain, the more focused the physical exam can be, and the more feedback you have for the patient when they return and say nothing has changed. For patients, being in pain is very black or white. Either they're in pain or they're not, and until they have no pain, they think nothing is changing with the treatments. If this is the patient's focus, they will always be disappointed. All types of pain have parameters that will change long before they experience no pain. Anytime a patient comes in for treatment, I want to change at least 1 out of 6 parameters of pain. The character and location of pain tend to be the last 2 parameters to change. However, the intensity, frequency, duration, and activities to onset of pain start to change early in therapy. This is where I get patients to focus. So let's tease apart what each of these parameters mean. What information does the character of pain provide us? The character and location of pain help isolate what tissues are involved. This is one area to really challenge your patients for accurate descriptions. Saying that they are in pain, it hurts, or it's sore doesn't tell us a thing. What words would patients use to describe musculoskeletal pain? Basically, here it can run the whole gamut, because this is where we have the highest density of discretionary nociceptive receptors. Sensory fibers gives us the opportunity to distinguish between sharp, dull, vibration, light touch, deep touch, hot, cold, and more. Muscle pain, including referred muscle pain, can be dull and aching, cramping, stiff, burning, or throbbing. For example, classic quadratus femoris syndrome, which is significantly more common than piriformis syndrome, particularly in women, is a burning, throbbing ache over the lateral aspect of the thigh that can sometimes extend down to the lateral lower leg. In general, muscle pain is worse with activities and improves with rest. This is a good differential for back pain. Mechanical back pain is worse with weight bearing and improves with rest. Whereas visceral back pain, particularly kidney back pain, is worse with rest and improves with movement. In general, muscles are assessed during an evaluation of the patient's active range of motion. Joint pain can originate from either the ligaments surrounding the joint or from a degeneration of the joint surface. Joint pain can be deep and aching, stiff, grabbing, throbbing, or sharp. Joint pain that is worse when moving the joint through a specific range of motion or while on uneven surfaces indicates a problem with the joint ligaments. And a good example is classic SI joint pain that is sharp and grabbing when standing from a seated position. Joint pain that is worse in a weight-bearing position regardless of movement is indicative of degeneration of the joint surface. A characteristic sign of joint inflammation is an increase in pain and stiffness following episodes of rest, where the inactivity creates a gelling effect within the joint and requires movement to start lubricating the joint surface again. In general, joints are assessed during an evaluation of a patient's passive range of motion. Bone pain is an intense, deep, boring ache, sometimes worse at night. Bone fractures are highly sensitive to vibration. Fractures can be more easily isolated with a 128 Hz tuning fork than with an X-ray. Finally, what words would patients use to describe nerve pain? It could be sharp, stabbing, searing, zingers, electrical, hot poker, or burning, and they will tend to be very specific in the location of pain. But it could also be numb, dead, or pins and needles, in which case they'll be more vague in identifying a location. How do you differentiate radicular from neuropathic pain? Radiculopathy is a lesion of a specific nerve root. For example, a lesion of the L5 nerve root before it enters the lumbosacral plexus, such as foraminal compression by a herniated disc. The patient will experience pain in the dermatome, weakness in the myotome, and a reduction of the tendon reflex associated with the L5 nerve root. Neuropathy, on the other hand, is a lesion of a formed nerve that contains multiple nerve roots. For example, a lesion of the sciatic nerve, which leaves the lumbosacral plexus containing the nerve roots of L4 to S3. The patient will experience pain and weakness anywhere in the distribution of the sciatic nerve. What words would patients use to describe visceral pain? Whereas our outer body has a plethora of discretionary nerve receptors to provide us with a massive amount of information about the interaction of our body in the world, we would go insane with digestion alone if we had that amount of sensory information coming from our inner world. We have only one type of receptor for our viscera and cardiovascular system: a stretch receptor. Therefore, all pain information coming from our inner world is a variation of stretch. An acute, intense stretch can be perceived as sharp. A prolonged, intense stretch can be perceived as pressure or fullness. And variable stimulation to the stretch receptor can be perceived as cramping. Cramping is affiliated with structures that have a peristaltic movement, such as the small and large intestines, ureters, or cystic duct. The waves of cramping follow the peristaltic cycle of muscle contraction when the movement is blocked, unorganized, or unable to move something along. Stretch receptors have a very poor ability to localize pain. The zone of localization for a particular stimulus, such as touch, for somatic nerves range from less than 1 millimeter on the fingertips to approximately 2 inches on your back. Visceral nerves are unable to localize where the nociceptive information is originating from. And visceral nerves often cross-stimulate multiple neighboring nerves, which is why appendix pain can commonly be found in the upper gastric region. To localize visceral pain, we use different types of palpation. What does it indicate when there is an increased pain or pressure with a slow application of deep palpation? A pathology in an organ where the organ is unable to adapt to the application of pressure. What does it indicate when there is an increased pain after the rapid release of that deep pressure, known as rebound tenderness or Blumberg sign? An acute inflammation of an organ or structure, and the pain will localize to the location of inflammation. Rebound tenderness can be performed anywhere in the abdomen, and it will still localize to the site of inflammation. McBurney's sign is rebound tenderness localizing to the right lower quadrant, indicative of appendicitis. Whereas Murphy's sign is rebound tenderness localizing to the right upper quadrant, indicating inflammation of the gallbladder. What information does location of pain provide us? As you recall, the character and location of pain help isolate what tissues are involved. But now, not only are the words that the patient chooses to describe their pain important, but also how they indicate the painful areas. For example, if somebody is experiencing sharp pain, they know exactly where that sharp pain is located and will indicate the location by pointing with a single finger. If, however, a client uses a broad open hand to indicate an area of sharp pain, either they're experiencing sharp pain covering a larger area, which is not very common, or you need to spend more time exploring their perception and experience of sharp pain. Is the area small and isolated or a broad, vague area? Can the patient describe the boundary of the painful area? Clear-cut boundaries that are easily mapped out can be indicative of neurological lesions of the more superficial cutaneous nerves, whereas deeper issues of the neurological, musculoskeletal, and visceral systems have more vague boundaries. Can they trace the path or route the pain takes? Is there an anatomical structure that corresponds to that path? Directionally oriented pain patterns are more common in the external musculoskeletal body than in the viscera. Finally, where a patient experiences pain is not necessarily where the problem is. It is the last place that can no longer compensate. For example, unless your client is a football player that experienced an acute valgus stress on the knee, medial knee pain may not indicate a pathology with the MCL or medial meniscus. So what are the most common causes of medial knee pain with no history of a knee injury? In my experience, digestive disturbances and menstrual complaints. The location and character of pain will give us the most information about what is being affected. The next 4 parameters explore how the pain is changing. What information does the intensity of pain provide us? Most commonly, we measure intensity on a scale of 1 to 5, or 1 to 10, to objectify the experience. When using scales, it's important to clarify the reference range, such as 1 means no pain at all, and 10 means the worst pain you have ever experienced. It is also important to put the patient's personal experience into perspective. Please give me an example of a time when you experienced a 5 out of 10 intensity of pain. Now give me an example of what you would consider to be a 10 out of 10 intensity of pain. If the pain comes and goes, what is the range of intensity? This is a good way to objectify a patient's progress, particularly if they come back in and say everything is the same. Well, Mr. Jones, last week you said your pain was 8 out of 10. And this week you say your pain is 6 out of 10. That is a significant improvement. During reevaluations, or after you've been treating a client for an extended period of time, you may want to separate out changes in the intensity of pain from changes in overall function. What is your overall improvement in pain if 0% was your worst experience of this pain and 100% is the total resolution of this complaint, as compared to what is your overall improvement in function if 0% means you're unable to perform the activities of daily living and 100% is a total resolution of the complaint? Patients will generally experience an increase in overall function before they report changes in pain intensity. What information does the frequency and duration of pain provide us? Frequency is how often the pain comes on, and duration is how long it lasts once it has come on. For example, I get 3 flare-ups a year, which is the frequency, and each flare-up usually lasts about 2 weeks, which is the duration. Finally, activities until onset of pain is a great way to monitor treatment progress. For example, you can have the same character of pain in the same location, but now it starts after walking for 5 kilometers instead of walking for half a kilometer. That's great progress. These are only some of the most common pain patterns. Of course, your patient's clinical picture will be totally unique and influenced by the experiences in their life and their communication style. Please remember, the results of the physical examination must make sense in the context of the patient's clinical history. If it doesn't, then you're missing something. This also means your physical exam may discover the root cause of your patient's pain is in a different location from where your patient is experiencing symptoms. Don't let the pain distract you. Treat the root cause, not the symptoms. Thank you for joining me in this important clinical skill, differentiating pain patterns. You can discover more workshops and lectures on my website, integratedbalance.ca, or follow me on my social media platforms. Join me next time when we explore another clinical skill.